that, and then we can go back to your slides. So hopefully everybody can see that okay. So I'm pleased to introduce this first session today, and this is Mr. Alan Woodall, who is the clinical lead for integrated health and care research in Powys Teaching Health Board, and he'll be talking to us about cardiovascular risk in rural psychiatric inpatient populations.
Good morning, good afternoon everyone. So I'll just try and give you a quick whistle-stop tour. Just a little bit of a background. I'm not a psychiatrist, although I oddly work entirely within the mental health directorate now. So background was I was a research scientist, biochemistry, biophysicist, PhD, postdoc before I went back into medicine. And then I spent 15 years as a GP doing really remote rural. Powys is quite urban to me compared to the Highlands of Scotland and working in Bangladesh and things like that. So I did disaster medicine for about 15 years. But then came back to do some research after spending a lot of time doing mental health. And now I work half of my time with the mental health team, half of the time out of hours as a GP, and the rest of the time leading research activity in Powys. I'm funded by Healthcare Research Wales, and I've got an NIHR grant as well that I work in collaboration with the Universities of Liverpool and University of South Wales. So we're going to talk today about cardiovascular risk for people with severe mental illness and why that's really important and why it's something that really motivates me. So what's the problem? It's a big killer. Cardiovascular risk is underappreciated in people with serious mental illness, and by that we mean people with schizophrenia or bipolar disorder or psychotic disorders. We've been doing some work, and I'll talk a little bit about our work on how we estimate risk, and we use a tool which is an NHS validated tool called QRisk3. We've done a little pilot study just to gather some initial information to support a research grant application. We'll be talking a little bit about what sort of changes we need to make in how we deliver care to people with serious mental illness. But let's talk about, first of all, what's the problem? Well, if you're somebody with schizophrenia or bipolar disorder, you'll die about 15 to 20 years earlier than the average. That's a terrible statistic. And most people think, was that due to people dying of suicide? Well, suicide only accounts for around about 1 in 5 of those excess death risks, those early death risks. 70% of them are due to cardiovascular disease. That's early heart attacks or early strokes. So it's the biggest killer of people with serious mental illness, and we manage that risk very poorly, frankly, in the NHS. Why do people die? Well, some of it's fixed and some of it's lifestyle and some of it's inequality. The rates of smoking in the psychiatric inpatient population is very high. 60 to 70% of people who have serious mental illness smoke. The average now is about 15% in the general population. Many of them have poor diet, which results in high cholesterol and lipids. They develop obesity secondary to the illness and secondary to some of the drugs that we treat them with. And they often have, due to their illness, quite poor exercise. Many of these people fall down the poverty gradient. They end up in the worst housing, with the worst food and the least access to care. And then there are other factors. The drugs that we use to manage them increase their risk of developing diabetes, it increases their risk of developing obesity and their cardiovascular risk as well. For many patients in rural areas, access to services is really difficult. It's very difficult to get to your GP surgery, and we'll talk a little bit about that. And there's a bit of a, it's not my job syndrome. I hear that from GPs and I hear that from psychiatrists. My job is to try and bridge the gap between the two. And that affects all healthcare professions and social care professions. So how do we calculate it? Well, the NHS has a validated tool called QRisk3. It's been well investigated and tested on millions of patients. And this will actually give you can look it up yourself and you can run it on yourself if you want to at that website. It gives you a 10-year probability of you developing a stroke. So I can literally, within about 5 minutes, generate a score and say your risk of developing a heart attack or stroke based on your factors is going to be about 7%, for example. And that's quite a useful tool to be able to explain to patients their risks and what we can do to modify them. It's free to use and it takes 5 minutes for a clinician. It takes very little training to use it. It might not display too well. This is the QRisk calculator. It takes a number of factors, some factors which are relatively fixed, such as your age, your sex and where you live, for looking for deprivation, what your ethnicity is. And then other factors which are modifiable or non-modifiable, such as your smoking rates, whether you're diabetic, do you have a family history of heart disease, a range of other treatments. You'll notice here whether or not you have a severe mental illness, because that's a risk factor in itself, and whether you're on a drug called an atypical antipsychotic because of that. It'll ask if we know it, if we can get your cholesterol level, we can get your blood pressure, we get your height and weight. Putting all that information in will give us a tool, and it gives us a calculation of that tool. Very simple to use. GPs use it very readily. It's not used so much in the hospital or community setting. I'm going to give you an example. This is a bit of an amalgam, but it's a real patient. So Bob was one of my patients, different area of the country. He was a 35-year-old man, married with 2 kids, schizophrenia. He was put on a drug called olanzapine to treat his schizophrenia, and that causes massive weight gain, and it also increases the risk of diabetes. And over the 10 years that Bob had been on that drug, he put on about 15 kilograms. He developed diabetes secondary to his illness. Bob had a few risk factors though. His dad died early of a heart attack. Common to most people with schizophrenia, Bob was a heavy smoker. He was getting erectile dysfunction, which was partly giving him a problem, secondary to his meds, but also was having a relationship difficulty due to that. His blood pressure was okay at 140/90. His cholesterol was, we consider that borderline to high, a TCA, total cholesterol of 5, with an HDL of 1. So if we actually run a calculator for somebody of Bob's age and sex and ethnicity, what is his risk? 35-year-old male, doesn't smoke, normal weight, normal blood pressure, etc., no illnesses. The risk of an average person for that would be about 0.7%. So not many people will develop a heart attack or stroke at 35 in the next 10 years. And you know that from your own experience. Just shout out what you think Bob's risk might be. What do you think Bob's risk of a heart attack or stroke in the next 10 years might be?
15.
15? Anybody else?
7%.
7%? Yeah. Thank you. Anyone else? I'll do one more. So we've got a high of 15 and a low of 7. Anybody else? Nope. Okay. Bob's risk. Bob's risk of a heart attack or stroke is 42.5%. He's nearly almost half as likely to get a stroke or a heart attack. And Bob did die of a heart attack at 41. His risk is 64 times that of the average age of his male. And we can use the tool to calculate something called your heart age, which will tell you if you're fit and healthy, your healthy heart age should be 35. Bob had the heart age of somebody of 84, and that was due to his illness. But we can deal with that. We can reduce that risk, and it's not that difficult if we actually coordinate services really well. So, interventions you can do, get your smoking down. We don't have to quit, but if we can help you get that down, get a bit of weight off, get your blood pressure improved with blood pressure tablets, and get your cholesterol down with a statin. And we did achieve those things for Bob or Bob's equivalent. And if you do that, you can see that you can bring that risk down quite considerably. You're not making massive interventions, but you can significantly reduce that risk. And with really intensive effort, if you can help that patient quit smoking, get their weight normalized and get their blood pressure normalized, you can bring that risk down a heck of a lot. It's never going to be normal, but you can bring it down a heck of a lot. So these are really important things to get right for patients like Bob. So I'm going to talk a little bit about my research, and I've only started in April, so you have to forgive me. A lot of this is just pilot data that we're just generating. One of the first things I did coming in as the integrated care lead for the health board was I could choose which department I wanted to embed myself in, and I chose to embed myself in mental health because those are the most vulnerable patients. I have an interest in psychiatry as well as general practice. So the first thing I wanted to do was let's go into our general adult ward. For Powys, we have one ward which looks after anybody that needs a psychiatric admission, and I went back through every case record for the last year, looking at, do we capture the information to be able to do a Q-risk examination? If we can, what was that score for that patient? What are we actually doing when we've got them there? Some of these patients might be in for, the mean is 50 days, so they're in for quite a long time. Could we do something about it? And what do we need to do next to try and improve that? So there's 168 admissions through the year. The Q-risk calculator runs from 25 to 84 years. So quite a few were below the assessment age. Some already had pre-existing cardiovascular disease, and you can't use that. And some of them had very short admissions, and we felt that you needed time to engage with the patient. You can't do all of this in just one time. So we excluded that. So we looked at 75 met the admissions and met the risk assessment criteria. Some of those were repeat admissions, so there were 57 individuals that we looked at. When we actually look at that, that's the cohort characteristics. Their age range from 25 to 69, about half are men. Typical for Powys, the vast majority are white British. We do have some ethnic minority populations that have lived and moved into the area. 70% were detained under the Mental Health Act. That's fairly common now. Most people in psychiatric inpatient units have probably entered through detention. And quite a lot are in for a long period of time. You can see some of those patients might be in a year. The mean is around 50 days. 7% were diabetics, and smoking rates typically falling with what we see from other studies. We know about 2/3 of our patients smoke. 11% had a diagnosis of high blood pressure. 63 had a serious mental illness. That would be schizophrenia or bipolar disorder or a severe depression. Some have other illnesses, which mean they will get admitted, such as personality disorder, and they wouldn't be classified as a serious mental illness, but they still are at risk. And the common drugs that we now use to treat psychotic illness are what we call atypical or second-generation antipsychotic drugs, like risperidone or olanzapine. And these are very good drugs. They miss some of the side effects that other drugs present with, like Parkinsonian symptoms, but they do increase obesity and weight gain and diabetic risk. So when we actually look at that, it's quite difficult, actually. Powys is still a bit, I make no apologies for this, and this is one of my jobs. It's still a bit behind the times. We've got a lot of patients, we're still using paper notes on our wards, multiple logins. If anybody works in the NHS in Wales, you'll realise that you've got to go to Welsh Clinical Portal for this, and you've got to go to another system for that to get different blood results. So it's quite hard. But when I actually looked through, we were capturing most of the Q risk variables we'd need to capture. So I thought, well, everybody was getting a blood pressure, everybody's getting a weight, everybody's getting a cholesterol done. Why the hell are we not doing anything with the results? Some factors were badly recorded on admission. So very few of the psychiatry team were asking if there was any early family history of heart disease. It's not a standard question on the proforma they ask. Wasn't always recorded accurately what their smoking status might be. It might be yes or no, and what we really need to know is how much you smoke, because the quantification is really important. Most of our patients would have a blood pressure done. You think, well, why not all of them? Patients can refuse, and patients who are admitted under detention or often psychotic will refuse to have investigations done. So they'd often refuse to have a blood pressure or a weight or a cholesterol measurement. But one of the things I've driven is to try and ensure that that isn't asked once, that we should be coming back and asking a week later, and then a week later, and when they're starting to recover and that psychosis is lessening. Let's get in and let's challenge these things, and it's important that we challenge it now. When we actually look, their Q risk score for the inpatient population is 7.3%, their matched age control is 2.7%, their relative risk of heart disease is 3.8 times that if you're a psychiatric inpatient. And it adds about 11 additional years onto your lifespan. The highest Q risk in our population that we got had a score of 31%. Males are much higher than females, so the relative risk if you're a male in a psychiatric inpatient unit is nearly 5 times that, roughly double that of a female. So males have an excess heart age of about 13 years, females around about 9. There's actually no significant differences on Mental Health Act status. Whether or not you were detained under the Act or not didn't make a difference in this group. So what does NICE suggest? So NICE, National Institutes of Clinical Health, suggests that anybody that we do an assessment of their cardiovascular risk score, if they've got a score of over 20%, they're at very high risk, or they're considered to be severely high at risk of heart disease. We really should be treating them with a statin. Over 10, between 10 and 20%, it's certainly a discussion you should have with the patient about whether or not the pros and cons of starting statins and other treatments are important. 28% of our patients had a score greater than 10%, and 18% had a very high score. And yet when we actually looked at those, only 1 in 5 were actually getting any treatment whatsoever to reduce their cholesterol or their blood pressure. That really pees me off, actually, as a doctor. I think, why? Why are we not dealing with this? And part of my research that I'm doing, my research is split into 2 main studies. So this was an evaluation just to gather some initial data, basically so I could browbeat some of my colleagues. part of my work is an epidemiology database study using the SAIL database, and the other half is interviewing with staff. So I'll talk a little bit about the interviews. So why are, this seems to have frozen, so let me just see if I can get it to move. Yeah, okay. What were the barriers? So in some of the early themes, so early thematic analysis, when I talk to it, when you actually chat to psychiatric consultants, most of them have done medical school and then 1 year of working on a ward as a junior doctor. And then after that, they get virtually no training in how to manage common risk factors like blood pressure or cholesterol. So when you ask them, well, you've got the result, why didn't you do anything with it? Why didn't you start? I wouldn't know where to start. I wouldn't feel confident. It's not my job. Common, so it was often said, well, we've got all of these results, and and so we've sent that out in the discharge letter to the GP to deal with. So we'll get the GP to do it. There's often the perception that patients won't take it. They won't take the advice. Oh well, one comment I had was, well, if I've got a patient that's 30 and they live to 50, I've done a good job. I don't think that's a good job. I think that's a SOP, actually, and I think we need to be dealing more with it. It is difficult to discuss these issues, so people who are psychotically seriously unwell, to try and have discussions about trying to reduce what's going to happen to you 20 years down the line, they are difficult discussions, and it is difficult to have them. But there are ways and means of doing it, and it's an issue that hasn't been addressed well by psychiatric teams, and it's particularly important in rural areas. I'll talk about why. So when I interviewed the psychiatrists, we found that they didn't feel that they had the skills or the training to do all of the interventions to reduce these risks. They felt it was very difficult, and their focus was entirely on the mental health and secondary physical health issues down the line. Well, that was something the GPs would deal with. Or, patients won't take it if we start. It's a very collusive attitude to do very little about. But when you interview GPs as well, and you ask them about, well, what are you doing when you get these letters from psychiatrists alerting you the fact that the patients have got high cholesterols or untreated blood pressure? The GPs themselves have low expectations that the patients will take treatment. Well, they don't come in for the tests, or it's very hard to get them to come in, or they won't take them when you prescribe. And there are some attitudinal attitudes around. There's still some negative stereotyping around serious mental illness by health professionals. But one of the biggest aspects when you talk to patients about this, especially if we send out letters to GPs to say, can you deal with this, is rural access. I've got patients that live 15, 20 miles away from GP surgeries. They might have, so if you're an antipsychotic, the chances are, even if you can drive, you've had your license taken off you. There might be 3 buses a week. They might find that their psychosis means that they're fearful to go outside unless somebody can take them to the GP surgery. They won't go to get the cholesterol checked. They won't go to have the discussion about their blood pressure. They won't go to the smoking cessation services. So it's very poor. It's very poor access. It's even harder for people with serious mental illness. And many of these patients are on, next to nothing in a cost of living crisis, and they can't afford the £1.50 bus fare. They should have free bus. They should have. They need to have free access. Really, there is issues with poor motivation. People who have psychotic illnesses are often had. They've had a really difficult life, and the motivation to think about wanting to be alive when you're 50 or 60 might not even be there. And it's about how we address some of those issues for these people down the line. So what are we doing now? Well, the Health Board have me. I'm oddly a GP sitting in the Mental Health Directorate who badges his colleagues. So I now go in and do a proactive Q-Risk-3 assessment and intervention, physical health. Basically, I'm doing a GP's job for everybody while they're on the wards. And I'm also training up staff. So I've got a fantastic clinical nurse specialist who's training, and I've got a fantastic occupational health therapist. So we've looked at some of the services which are in operation, and the services are not fit for purpose in terms of prevention. So smoking cessation, there's a one-size-fits-all service. It makes no allowance for the fact that you might have a mental illness. It's very much driven by the patient to attend and opt in, and we need to reconfigure that. We need to develop bespoke services for smoking cessation, weight management, and exercise on prescription. We need supportive, fast-track earmarked specialist services for these patients who are the most vulnerable patients we have. We're doing simple things like teaching cooking skills. Many of these are patients who wouldn't know how to do anything other than heat up something in a microwave, if that. So, you know, a lot of my patients would be, it'll be whatever they can get from the chip shop or whatever's in the Beyond Best date in Tesco. So we now going to be rolling this out to offer an annual assessment of cardiovascular to all of our psychiatric outpatients in Powys as well. And I'm training up the team. So that's what I'm doing now in terms of intervention to change that. So nobody now should leave our ward without me having had an assessment with me and having the opportunity to discuss that. And certainly I will liaise with colleagues to ensure that we pick that up and we'll audit what the fallout rate will be. The research that I'm doing, so I'm doing a big epidemiology study looking at all psychiatric inpatient admissions in Wales and looking at their Q risk scores relative to a matched control and looking at the factors that might influence that. The other half of my research is looking at assessing barriers to care, and that's done by thematic analysis with healthcare providers, with so that's GPs, with psychiatrists, with other health professionals, and there are barriers to access, and there are attitudinal barriers about why we're not intervening. I'm also interviewing with health policymakers, so with the Welsh Government, with the deaneries. So how we've got to the stage where a psychiatrist can't prescribe a statin or a blood pressure tablet, which should be common to all junior doctors, is not acceptable to me, and so I'll be challenging that. And equally, we have training needs for GPs, particularly around they are very reluctant to manage antipsychotics. If patients discharged on them, they just leave them sitting there whether they need them or not. They're too fearful to deal with that. We've got a grant application that we're just working up. So one of the problems I have in Powys is the lack of integrated electronic healthcare systems. So I'm working with the University of Liverpool and Merseycare, which have a unified inpatient, primary and secondary care database system. So we can actually develop. And one of the things we're looking at is actually designing those bespoke fast-track earmarked smoking cessation services, fast-track earmarked specialist services. So dietitians who are trained to work with people with mental health problems, rather than you just go into the standard service that's been offered. So that's what we're currently working up now in terms of the research efforts that we're doing. So I'll stop there really. So just to thank, so Healthcare Research Wales were daft enough to give me a Research Time Award to do this. So I've been doing that. I have to be very thankful to the Mental Health Directorate, because they have allowed me to dip in and do these things. So I'm working with Ben and Joy. Amy is the clinical nurse specialist who is training up to, she's getting prescribing, so she'll be starting the statins after discussion with me. And Millie's doing a lot of the work to try and see how we can reconfigure some of the preventative measures. The research team I work with in Liverpool, fantastic team, Lauren and I, both work on, our main grant is actually on developing AI tools for polypharmacy to support GPs to make the best evidence-based decisions on how to manage people on multiple drugs. And Ian's the lead prof on that, and he's a really good fan of that. So that's it really. I just wanted to give you a brief overview. All right, thank you very much.
Thanks very much indeed. Are you okay to take a few?
Yeah,
questions?
Absolutely, yes.
Will you have any from the floor? I've got one.
Yeah.
The people who don't stay in for so long, are their risk factors higher than?
Their risk factors are high. They're not as high as those that stay in along. So quite a lot of people may be admitted to what we call a crisis bed, which will be overnight. It could be an emotional upset where they've threatened suicide, but in reality, after a night in a bed with a bit of care and compassionate support, that risk is massively reduced. So part of the time is to actually have the time to work them up. So you can get admitted to those beds, but they wouldn't get a blood done, for example. They wouldn't get a blood pressure or weight. They'll be very quickly turned around. So I haven't got the ability to get all of the data that I'd want on them, which is why we focused on those that have been in for a week. We felt five working days is long enough to get all of the data that we need. I have ran the data, and they sit as an intermediate group, but there are more holes in those numbers. But there are ways and means about dealing with that, and that will be how we would deal with that through the outpatients, because many of these patients will still be under the care secondary mental health, but they're often very reluctant to go to their GP to get things done. So if they're coming for a depot or for a medication review, why the heck not do it when we've got them?
So the crisis teams and people like that.
Yeah, so
the community.
Yeah, so one of the things I've been doing is, hitting the head of my assistant director, say, well, I need ECGs and blood facilities in all of our clinics so we can do it when we've got you. I don't want to be writing to say, dear GP, please will you do an ECG and bloods for me? We can do them when we've got them. Yeah.
Any more questions? No?
Yep.
I wondered what's in terms of these lifestyle interventions, with smoking and weight loss, what's the kind of reception been like from these inpatients? They're kind of engaged.
Yeah, a rough rule of thumb, and I can't give you anything more than sort of a subjective feel. We get many patients who are reluctant to engage. That's not uncommon, actually. So if you look at what we call behaviour change, there's something called the trans-theoretical stages of behaviour change. So usually very few people will make an immediate decision to switch. So most of the evidence in the general population is that you go through what we call a preconceptual phase, and then a contemplative phase, and then an engagement phase. It's called a stages of change model. So what you're actually doing is often it's just raising the discussion. And even if you raise the discussion, what it's been shown is if that 5 or 6 people raise that discussion over maybe 2 years, people move down the cohort.
They slowly make that
Yes,
progress.
so you might not actually get someone to engage. So you could think, oh, well, that's a failure. They don't want smoking cessation. But what you're actually doing is it's just raising that discussion. But we do, and we have had patients who have had smoking cessation, which have started on the wards, who then successfully can reduce their smoking. We only had 1 or 2 that have actually quit, and I don't know what their long-term follow-up of whether that's maintained. But you can make those changes, and it's about that sustained reinforcement of message that it is okay to have the discussion. It is okay to say no, but we'll have the discussion again. And what I'm saying to you, you have value to me. I'm not going to pretend it's not important. So if you come back to see me in 6 months, I'll have that discussion again with you, and it's fine if you say no then. But what happens is we know that they move down that cohort.
So I guess it's integrating that long-term view of checking in with people and repeating that conversation.
Absolutely.
That's something you're trying to integrate.
Yes, It's about change. It's about changing that mindset that we should be offering these patients exactly the same that we offer any other patient, and it's also about saying discussion. Even if they say no, that doesn't mean it's a failure. It will change awareness, and many won't. And we have to recognise that it's a difficult to treat population, but it's that shouldn't be an excuse for not doing it.
No, absolutely.
Yeah. Thank you.
That holds true of the general population.
Absolutely.
Well.
Yeah.
And also the important thing is to get all the stuff integrated into their care pathway.
Absolutely.
Not expect them to do special things to get.
Yeah. Absolutely.
Brilliant.
Okay. Thanks very much.
Thank you. So I think, as far as I remember, I've been running up downstairs. It's now lunchtime night, so that'll be a popular show. So we're back in the main hall. So if they haven't quite finished over there, can you be quiet when you go in? They've got a link with grants, hopefully.
Yeah, I will be in the pilot data, the numbers are just too small to draw. But yeah, so the database, the SEAL database covers 85% of the lodge population now, which is in general practice. We have about 8,000 patients at the minute a year into psychiatric units in Wales and external to Wales. You've got enough population there to actually start to break it down and look at. We've got the lower output, super output area. We can use the Welsh index and multiple deprivations. We can look at that, and we can do so effectively. What you're asking is multiple logistic regression analysis, looking at variables. Yeah, that's part of the epidemiology work that we should plan to.
Thanks, Alan. I'm Mary Greenwich. I'm a colleague of Sid's. So, as a disclosure, we actually work with this area. Based out of Swansea University. A really interesting work, and it sounds like you've got a lot on, and I certainly wouldn't suggest you taking on anything else on top of what you're doing. But you did mention there about the need to go outside of Wales in order to do your random clinical trial, which is quite interesting because we have the trials unit at Swansea University who works with the SAIL data bank. We do know that the sign-up of GPs, as you know, is that we're up to about 85% coverage.
Yeah.
But it does occur to me, and I was having this conversation with my colleagues recently back in Swansea about what can we do to that final push to get GPs to submit their data, because it is one of SAIL's biggest unique selling points, especially even compared to England, where we can join primary care, secondary care, critical care, outpatient care, and increasingly social care-based services as well. And it just seems that it's just another way that rural communities are disadvantaged because us as researchers can't access their data because GPs are not willing to sign up to this.
I think there's been a lot of fear around when GDPR came in. I think it created that false fear.
Absolutely. Well, the care.data scandal, I think, even prior to that, and we can even map it. So when we look at the populations in Wales that we have covered by the GP data,
I'm looking at my denominator, I can see it going down.
Yeah, and it's a huge issue, and some of that is to do with the challenges on GP practices. If they serve an English and Welsh resident-based population, they perceive it's like, oh, I haven't got this work. Like, how can we figure out, only supply the Welsh data to SAIL and not, need the English data. It's frustrating because we have an entire organisation and an army of dedicated people who'd be willing to help that, but it seems to be perception on the GP side.
It is. To be honest with you, the real issue isn't so much primary care data, it's the secondary care data. So for me, just to do that pilot study literally involved going and dragging out paper notes and flicking through page after page looking for where someone's written their blood pressure. In Mersey Care, I can press a button and see immediately, because they're using an electronic integrated care, which is one of the things that I'm leading on in Power System to move towards an electronic care system. And I think once we've got that, we get a much more rich data set. We'll get new data sets that we'll add into the SAIL.
Yeah, brilliant. Excellent. Well, it's really great.
All right, it's nice to meet you guys anyway. Thank you. So I'm literally have to dash off now and do a mental health assessment for 1:30 in Breakout. So I'll catch you in a bit.
Sorry, Steve.
No, that's fine. Thank you. I'll probably catch you when I come back.
Yes. And lunch. Right. Well, I think we better go for lunch. Human prices. Oh, 79 89 89 56 44. Right, so what time is
2:30,
right?
I think.
Okay, I'll come back over about 2:15.
Yeah, 2:30.
Right.
And you're
Then when I am, don't message me because you've got my battery and I know this is about going flat. Okay.
Thank you so much.
No problem. Oh, God, it's raining now.
Alex, am I right in thinking that you're presenting from your side?
Yeah, I can. I've got it here, so I can pull it up. Yeah, no problem.
Okay, great. If Anna appears, it may be that she's got it ready to go, but just in case. Brilliant, thank you. You've got a couple of minutes.
Couple of minutes, is that?
Yeah, I think so. We'll hang on a couple, because I think there's a bit of time with people moving between rooms, and then we'll go from there.
Thank you.
Thank you. Okay, I think we might make a start so that we don't run over too much and can get back into the main room in time. So presenting first, we've got Alex Walsby, and she's presenting around team around the patient supporting care delivery in hospitals. Can I hand over to you, Alex?
Yes, you can. Am I able to share my screen whilst you're still doing yours?
That's a very good question. I shall take this down. I didn't realise Anna was sharing, sorry.
Yeah.
There we go.
Okay. Has that come up?
Yes.
Yeah, lovely. Okay, so good afternoon. I'm Alex. I am the lead nurse for Professional Standards and Assurance in Health, our Health Board, and I'm also a PhD student at Swansea University, and I'm researching team around the patient. So as a quick overview, this presentation will just go over the background and motivation for the study that I'm doing, what we're aiming to achieve, how we've gone about it to date, some very early results, and what the next steps will be. So the background for team around the patient has very much been driven by the deficits in registered nurse staffing. That's where we've started from. That's not to say that the focus of it is all about nursing, but that's certainly where we came at it from. So we've got some statistics to show there. On the left, we've got some data specifically from Wales, which was published by the RCN Wales last year. At that time, it showed vacancies of just over 1,700. We know that there's been more recent statistics published just a few weeks ago now that show that we're actually now up to about 2,900 registered nursing deficits within Wales. We know that our workforce are working significant amounts of overtime. That's from the staff that we employ. And we also know that we are spending a phenomenal amount of money on temporary workforce, so through agency nursing. The spend in 2019 was over £69 million. So from more nationally from the UK, the data there is a little bit more up to date. It was reported earlier this year. But we could see similar challenges nationally. So there's about a quarter of our shifts are not meeting their core complement of registered nursing staff. The nurses that we are employing are 69% don't feel that the numbers are right, that they've got the right levels to give the care that their patients need. 81% felt that care was compromised due to not having enough nurses on shift. Our nurses felt demoralised, and a significant number weren't able to take breaks, and 63% reported working additional overtime. So that really just gives us a bit of a flavour of the challenges within registered nursing. Wales and nationally, and why this project was seen to be so important. So back in 2013, Welsh Government published the Prudent Healthcare Agenda, which is all about health and wellbeing for future generations within Wales. And although this is obviously 9 years old now, there are some really pertinent points in it that we've carried into the team around the patient concept. The first one being only do what only you can do. And by that we mean, so particularly from a nursing point of view, we want registered nurses to fulfil roles that they can't delegate, that really do take a registrant to be able to fulfil. And to be able to do that, we need to release them from a lot of the other tasks that are potentially delegatable to other staff groups, other professional bodies. We need to be able to form equal partnership. There's co-production between professionals and the public and our service users to really understand what it is that our patients need and want and how we can aim to achieve that. It's team around the patient is crucial to working within disciplinaries, multidisciplinary, but also considering what else there is in our communities that can support care delivery through our public sector, through third sector, and even through industry. And it's how we can utilise those resources best to put our patients at the centre and meet their needs. And ultimately, what it will aim to achieve is that we can deliver care and support to our patients in the right place at the right time, by people that are suitably trained and skilled and competent to deliver that care. So from a HALSR point of view, we're looking at team around the patient as a case study. So that's the approach we've taken. I'm researching within HALSR, however, we know that nationally this work is being picked up as well through RHCW. But from our point of view, we have started off within one of our DGHs within Glangwili. So HALSR serves a population of approximately 384,000. Within our patch, we've got 4 acute hospitals, 4 community hospitals, and of course a number of other specialities, mental health, paediatrics, community services as well. For the whole patch, as of September this year, we were just shy of 333 registered nurse vacancies to be able to deliver the care to that population group that we've got. So the aim of the study, the specific aim of the early research that I'm doing is to examine the perceptions of key health board stakeholders into what team around the patient, what a model of care could look like, and establish the research priorities. The methodology taken, the work is still quite new, so when we get onto the results, it is all kind of just the early findings at the moment. But the methodology so far has been to identify key stakeholders across the organisation and conduct a number of semi-structured interviews. The purpose of those interviews was to firstly explore the perception. So what is team around the patient? What could it mean? What could it look like? And hope to come up with a definition from the various perceptions that we found. Consider what our quality indicators could look like so that we've got some monitoring behind it so that we can recognise successes, challenges, areas of development. Consider what potential roles and skills that we already have within the organisation and how we can use those potentially differently or maybe just more readily. And also think about what barriers we might come against and what the enablers are. The interviews have been done and they will be thematically analysed using a framework developed by Braun and Clark. So we had 15 interviews in total. It was a response rate of 65.2% from the invitations that went out. They were all held virtually. They took about 30 minutes each and they were done between May and July of this year. We had quite good representation across the organisation, so we managed to get representation from some senior corporate nursing colleagues, including our Director of Nursing and the Health Board. We had people from workforce planning, workforce culture, learning and development. We managed to get some operational engagement from senior nurses and some ward sisters and charge nurses. We included therapies, pharmacy colleagues, patient experience colleagues, and we were able to get some people from a discharge point of view. And we also had the nurse staffing programme lead. As mentioned, they were semi-structured, so the structure of the interviews, firstly, dug into kind of what people perceive team around the patient to mean, what the definition could be, the quality indicators, the barriers enablers, but we also thought a little bit about workforce planning implications, what the impact on the organisation might look like, and if there were any legislation factors that we had to consider. And really around that point, we were thinking about the Nurse Staffing Act. So the results on the screen now, there are some direct quotes from certain individuals. I think it's fair to say that the perceptions were a little bit different depending on the professional background of the person being interviewed. However, there were some really core key similarities that kept popping up time and time again throughout the interviews. So from those, so far I've pulled out what the commonalities were to be able to come up with the definition. So the working definition at the moment is that team around the patient aims to enable the delivery of effective, safe, patient-centred care that best uses the skills and experience of a multidisciplinary team to achieve the optimum outcome for patients and patient experience. So then we were thinking about what the contributions, what it could actually mean in practice, what it could look like. And the first thing that came up was working at top of license. So that again goes back to the prudent healthcare principle of people doing what it is that only they could do. So if they are released from tasks that can be delegated to other people, they are able to work to the top of their license and do what it is that only they have the skill to do. It's very much about multidisciplinary working. When I started the presentation, I said that we came at it from a nursing deficit lens. However, it was clear that from all the stakeholders that actually it is about changing the cultures, sort of breaking down professional silos, getting multidisciplinary team members to work more cohesively together. We considered existing roles that might be in the organisation that we're also using, but we also then thought that potentially there might be some role redesign work in the future. I think once we have exhausted the resources that we've got and sort of use those to their optimum and reevaluate, then if there are still more gaps, then that might be when we then consider what can we design from a role that would fulfill the gaps that remain. There's a real hope that team around the patient will aid retention, it will aid recruitment. I think that's born from some of those statistics we looked at quite earlier on, where staff were demoralised, they weren't taking breaks, they were burnt out essentially. That by boosting and bolstering the workforce appropriately, that some of those pressures might be reduced and it might aid recruitment and retention. It would also hopefully aid career development and career pathways. I think if we're thinking about how we can bring people into the organisation, into new roles, often non-registrant roles, we can then think about how those pathways can be developed for them so that they can see progression and that we've mapped it out and that there is support to achieve that. And that might be ultimately going into registrant roles, it might not, it's going to depend on the individuals. There's a hope that we will have quite a flexible workforce. We'll have lots of skills within the workforce. We'll know where those skills are, who's holding them, and that will give us a degree of flexibility and adaptability. And that ultimately that we'll have a really values-based approach to the way we're delivering care, and that our patients really are at the core centre of that. So within health, some of the roles that we think that we've already got that can fall into team around the patient include Band 4 assistant practitioners. So we've already got them in practice, but we need to up the numbers, and we need to consider how that role is best used. So whether it's they can take delegated care for a group of patients, and whether in the future they can support medicines administration or those kind of options. Again, we've already got them, but pharmacy technicians have been so far, the early feeling is that they're a really valuable role. They can support us with our medications administration, which takes a significant amount of time from a registered nurse for those four classic medication rounds per shift. We're looking at physio and OT support roles, whether there's more we can do about kind of thinking of discharge from admission, the reablement side, the rehab side. Family liaison officers was something we introduced at the start of the pandemic, but evaluations of that role again have proved to be very positive. And they tend to do a lot of our communication, some of the softer skills, so some of the more pastoral skills with our patients, but also the link between hospital and home. So they can take some of the weight of the phone calls from the nursing staff. So it's not a clinical role and it's not designed to give any clinical information, but it can do more of the, as I said, the pastoral elements, both for patients and their relatives at home. Ward administration, again, non-patient facing, but really important in releasing registered nurses, particularly more senior, so ward discharge nurses, from some of the admin duties that maybe limit their time and the time that they get to spend clinically with patients. And then we're looking at social workers and third-party organisations, which are largely focused on the discharge element, things like people like Red Cross and Delta Wellbeing, and how we can bring those into our workforce earlier, maybe more structured, maybe more engaged, to think about the discharge from admission side for our patients. So what the stakeholders' anticipated outcomes are, again, there's some direct quotes from the interviews on the screen now. There was a consistent theme running through that it's about the patient and it's improving care delivery, and that was a consistent theme. But there was quite a lot about how it will affect staff and staff working and staff morale. So it's about staff having value in their role and wanting and being able to do a really good job, but knowing that they have the safety to express views and they feel comfortable and safe within their teams. There was things about how they have a sense of belonging, so that professional identity comes into it, how the professional development is there for them, how the culture is going to change. I think traditionally professional silos are quite well recognised. We train, so registered professionals train in silos largely, so it's how those can be broken down, that culture will change, and it's about people being happy in their work and being in a better place in themselves to be able to provide better care to our patients. So thinking of what the quality indicators, the measures of success or the identification of challenges might be, and the first one that came up consistently was about patient experience. So considering how we can include our patients in a lot of the decision making that happens day to day routinely throughout their care. I think traditionally people see it as being kind of led by the medical teams and the care deliverers, but actually the patients need to be part of those decisions as well, and we need to understand what their expectations are and what outcomes they want to achieve, which may be different from the initial clinical plan, and come up with a way of achieving that together. We hope that we will see a reduction in incidences that cause harm, recognise and acknowledge that incidents happen in practice, and some areas will have more than others. For example, a rehab area might see higher incidences of fall, but and accepting that we will never eradicate incidents from happening, but it's how can we reduce the harm that is caused by them. Equally, we'd like to see a reduction in any quality concerns that that are identified through mortality reviews. We would love to see a reduction in hospital length of stay for our patients, to be able to get them out of hospital in a more timely way, and potentially that might include having an improved functional ability on discharge as well. With our staff, as you'll be aware, we do survey our staff, we do monitor kind of staff feedback and staff experiences. We'd like to see improvements in the perceptions of staff working within the health board, and that in turn will hopefully lead into an ability to recruit into and retain into our vacant posts. Excuse me, and also result in a reduction in staff leaving their posts as well. And then the final one there is about roster compliance. So through the Nurse Staffing Act, we monitor whether we are meeting our planned rosters, but also whether that that roster is appropriate. So whether it's met or not, and whether those levels are appropriate to deliver the care that that patient group needs. So we'd like to see an improvement in that as well. So we recognise there's going to be some challenges along the way, and the things that the stakeholders thought might be a challenge is engagement from nursing teams. We know our teams are just so busy, and they're very tired, and they are often working short-staffed, and that really limits people's ability to be able to engage in workforce remodelling projects like this, and it can be quite difficult to see the wood for the trees sometimes as well, that this ultimately is going to hopefully help things, but it is going to take a bit of work and a bit of investment in the beginning to get there. Equally, the organisational engagement, again, I came at this from a nursing lens, but it would be remiss to not acknowledge that it's not just nurses that suffer with struggling with vacancies, and that it's a tired and stretched workforce. So it might be difficult, it might be challenging to find other teams that are able to engage with us. The culture in the organisation, we've already mentioned, we've talked about professional silos and breaking those down, and the hierarchical structure that you often find in healthcare organisations. Training times and pipelines is another challenge. Having mentioned some of the potential roles that could be useful, we know that to train a Band 4 assistant practitioner takes 2 years, and we don't have a whole host of them ready in the organisation to step into these roles if we created them en masse. So there is a bit of a long-term vision here, and yeah, the answer isn't imminent. Finance is, of course, going to be a consideration. Our finance colleagues would love to see that this project will result in savings. I think whether it will or not, we won't realise for quite some time, and actually whether we need to consider it more in a values-based way than a monetary way, potentially. And as mentioned, the operational pressures, just understanding how busy our services are limits the opportunity to engage. But the enablers there, it's on both sides as nursing vacancies. Having spent some time out in some of the nursing teams that are really struggling and have got multiple vacancies, they're willing to do anything that can potentially help them. So if they're investing a bit of time and a bit of effort now, if they know it's going to help them in the future, they really are willing to step up to the plate and work with us with it. Equally, multidisciplinary teams have had the same kind of attitude in early discussions about how we can make things better for our patients, because ultimately it does come down to what is best for our patients. The culture element, I think possibly coming out of the back end of the pandemic, has in this light maybe helped us to see that we can work in different ways, we can respond to crisis, and it's almost given us a bit of a kickstart that new ways of working are possible. So the next steps from my research point of view, at the moment, the research has been done within the Health Board. It's all been about how with our stakeholders. So my plan is to expand that to a more national, potentially international level. So I will be doing a Delphi study in the near future, which will explore the opinions of experts within healthcare leaders, academics, policymakers, to see if we can, if there's anything we can, any opportunities for learning from other areas that have had similar challenges and potentially come up with similar or different solutions. The case study is ongoing. The aim is to work on an admissions ward, a medical ward and a surgical ward. I've done some observational data so far on the admissions in the medical ward, which has involved time and motion studies. So it's allowed me to collect an awful lot of data that shows exactly what it is a registered nurse does throughout their shift. That data will then be analysed to look for opportunities for delegation to other professional bodies. However, it's probably worth mentioning that early analysis has suggested that although there are definitely opportunities for team around the patient, there are also some process challenges that could potentially release some time as well. So I think the plan first of all is to address the process issues. There's some around medications management. Then we would look at what additional staff groups could support those areas. After that, it will lead on to another re-evaluation, and potentially that's where role design might come in. So we are exploring opportunities for delegation. We will be, as my role at the moment is to report back on my findings and make a number of recommendations to the organisation of things that could potentially help. Of course, it's up to the health board whether those are implemented or not, and there will be various kind of pros and cons to that, and I'm sure some will be adopted, some probably won't for reasons that may not be obvious to me when I'm doing the observations. But once those changes have been implemented, there'll be a process of evaluation, and then there'll also be some work around the governance, so really making sure that those quality indicators are the ones that we want and need them to be, and that they are monitoring and feeding back the information that we need to make sure our care delivery remains safe, effective, patient-centred, quality. And as part of all of this, there will be some work done on tool development. So at the moment, we're focused very much on specific ward areas, but obviously we want to create a model that could be implemented in any of our, particularly inpatient work at the moment, but potentially it could expand further than that. So we'll be looking at developing some principles for team around the patient, developing the governance structure and the evaluation structure for it. So there's just a few references from some of the references that I made throughout the presentation, and I would welcome any questions.
Brilliant, thank you very much, Alex. We've got time for a quick minute or two before we move on to the next one. There is a question online. Do you think that it should be obligatory for doctors to do more physical health training before they go into psychiatry? I'm wondering if that is from a previous talk. It doesn't really make any sense to yours, does it?
No, not one I can.
No, go back in time. I think probably that's an old question. I won't make you answer that. Are there any other questions either online or in the room for Alex? In the room. I mean, it sounds like a huge piece of work, Alex. I suppose one of the things I was interested in, you talked a bit about the potential that there may be new roles that you think could fit into this. Do you have any insight at the moment as to what kinds of gaps there might be that, or what kinds of skills or roles you might be looking at?
I think it's probably far too early to say, and I think that's probably why I'm very keen on, first of all, addressing any process issues within wards that come up, where time is maybe not used most effectively, and then using the roles that we already have in the organisation. I think it would be remiss of us to jump straight into what new roles can we create when we already have roles, we already have training plans for roles, for example, assistant practitioners, pharmacy techs. So I think it's really important to make sure that we're using those as effectively and efficiently as we can before we then considered role design. And ultimately, I don't have an answer, because I think we need to do that and then reevaluate and see where the gaps were, see where the challenges remain, to be able to then create something new, depending on what the need was at that time.
Brilliant. Yeah, great. Well, I don't think there are any additional questions in the room, so we'll let you off, but thank you so much. It sounds like a really interesting piece of work. It'd be really interesting to see how things develop going forward. Oh, there might be one. Sorry, you're not off the hook yet. There's one coming. Would you be working closely with the workforce planning at the health board to share some learning that could give immediate help to the work already being done, for example, tool development?
Yeah, so I do work quite closely with the workforce planning team, and they are also engaged in the national work that we'll be starting with RHCW. Yeah, so recognise it's not something we can do in isolation. It does need to be a health board approach with the strategic input as well.
Brilliant. Thank you so much, Alex. Really appreciate it.
Thank you for having me.
So, I don't know if anybody was wanting to shift between rooms, but if I'll give you a couple of minutes before the next one in case any. And Harriet, are you online? Oh, Jessica, are you presenting this one?
Oh, no, they're having difficulties.
Okay, that's all right.
I think they're in the wrong room, but let me just I've just given them a call. Hang on.
Thank you. Are you online with us now, Harriet?
Oh, hi, yes, sorry, we had some difficulties our end, I'm sorry.
No, it's been a day of tech difficulties today, don't worry.
Oh, gosh.
Are you happy to share? Have you got the presentation on your side to be able to share?
We're hoping so. Yeah, so we pre-recorded our presentation because unfortunately we couldn't all be together today. We've also got Jess Quill who has joined us as well. So I'm Angharad Williams. I'm a speech and language therapist, and today we are going to present the children's therapies project that we've been working on over the last year. I've also got
Hi, I'm Sharon Williams. I work for Swansea University and also the University Health Board, and I've been involved in the project as a coach.
Hi, and I'm Lindsay Walshaw. I've been a coach through the Equip project that the girls are on also.
Fingers crossed. We are going to try and share our presentation with you now. Can I check, Anna, how have others managed to share their presentation successfully before now? Recording. Are they recordings? You're on mute. You're on mute.
So far, yes, but the ones so far have been live sharing as opposed to pre-recordings.
Right, okay.
Is it just not uploading?
I'm gonna try something now.
It's looking promising.
Yeah, that's it, guys.
So we can see the slides, but we can't hear your sound. Can you hear me, Harad?
It's still not sharing, is it? Did you when you said it?
And we can see your slides, okay, but we
I
can't.
hear you, sorry.
You turn your volume up.
Oh.
You'd put the share sound on if you do the shared screen.
So when you're sharing your screen, Harad, can you hear me?
Yeah.
Can you hear me, Harad?
Yes, I can now, sorry.
So when you share the screen, make sure that you're also sharing the sound, because we can see your slides fine,
Okay.
but we're not hearing your sound.
I know what to do.
Rosa, and welcome to the Children's Therapies Quality Improvement Project 2022. My name's Diane Lewis. I'm an occupational therapist in Hywel Dda with a clinical lead in neonatal care. We also have Jess Quill with us, who's a physiotherapist based in Pembrokeshire. Eve Walpole was another physiotherapist on the project with us. Unfortunately, Eve has now moved on to pastures new. And Harad Williams is with us, who's a speech and language therapist based in Carmarthenshire with a clinical lead in early years. We also have Emily Davis, who's a speech and language therapist covering Hywel Dda, also with a clinical lead in neonatal care. Alongside us in the project, we were supported by project coach Lindsay Clark and Professor Sharon Williams, with the project running since October 2022. As a therapy service, we were accepted for the Quality Improvement Project as Cohort 2, with the previous cohort concentrating on redesigning the request for help process to access children's therapies. This project concentrated on requests from health visitors because the highest referrals came from health visitors for speech and language and physiotherapy for children under the age of 5. It was seen as a valuable opportunity to come together as OT, physio and speech and language to streamline services and information sharing across all of the children's therapies. So the project aim was to equip our health visitors with knowledge and resources to support their ability to request appropriate help at the right time. We hope that ultimately this will help validate the requests being submitted and reduce the number of inappropriate referrals. This in turn will reduce the time being spent gathering further information and/or reassuring families at triage. What we were trying to accomplish was to reduce the number of returned requests for help to therapy services by 60% by December 2022, therefore getting it right the first time.
What the data told us. So therapies were experiencing an increasing number of requests for help which are not considered appropriate. This was for a number of reasons. Inadequate information. Quality of information is not always enough to determine need. Information provided does not indicate a need for concern at that given point in time. We also captured data on how much time was being spent at triage due to the reasons above. In this example, you can see weekly requests for SLT input totaling 600 requests over a period of 18 months in Carmarthenshire for under 3s alone. Requests which have a clear and appropriate information on average take the triage team up to 5 minutes to process. Requests where the information is limited or from the information it is unclear whether there is a need for specialist input often take up to 30 minutes for the triage team to process. This often involves support from the admin and also then it delays the journey for the family. Understanding the system. So here we have an example of a fishbone diagram. We discussed the possible issues that we felt impacted on our request for help system. This is represented by the fishbone diagram here. We try to think of different elements affecting the health visitors' requests as well as internal processes. For example, understanding developmental norms across all milestones, and referring just in case. Also, one of the issues we discussed was the access to IT, being away from the office and not being co-located as we were before.
So how will we know if change has made an improvement? So we looked at some of the audit data, and obviously we were going to audit this periodically through the time spent and have a look at the same data that we gathered in that initial assessment. The time, so reduction in time spent not only at the triage stage, but for the health visitors themselves to fill out any paperwork. And most importantly, the patient's benefit. So there's no unnecessary delays in the patient journey, and they'd have access to advice in a timely manner and therefore help with any satisfaction from both the professionals and the patients and families themselves. So what changes can we make that will result in those improvements? So we looked at a developmental checklist to support their decision making to help standardise that across the 3 specialities and across the 3 counties when considering that request for help. This checklist also provides the advice with other signposting information to be shared with the families before they even consider that specialist service request. So we offer focus group and information sessions to health visitors across Hywel Dda to help gather that information and have that ongoing feedback. So part of our PDSA cycle, so we're just talking about this here. So part of our planning stage was to use a document from the Solent Trust, which has a huge developmental checklist as a tool to enhance the quality of their requests for help. So we completed a focus group with a selection of health visitors to discuss our project and show them this document that we were planning to use, and collected quite a lot of useful information and feedback from them. So the majority of that feedback was that the Solent document itself was too big and the document was not very user-friendly. So it'd be useful to have the information all in one place that would help guide from all three specialities. And then develop an education package that needed for the health visitors and students and for us to help deliver that constant flow of information. So as part of our actions, we've developed our own single checklist, which is in line with evidence-based practice and the previous Solent document that we'd shown, and also helps link with the Healthy Child Wales programme, which is what the health visitors themselves work with. We also developed a quick reference checklist, which will make it easier for the health visitors to carry with them, which will help guide them through there. We looked at lots of different ways of presenting this information to the health visitors, and with the influx of accessibility through Microsoft Teams and things like that, and equipment, we decided to develop what we call a Padlet, which we'll go on to later, which will have all the information in one place, and develop an online virtual education training package, which has an associated Teams channel, which everyone has access to once completed the training. So just 3 examples of our PDSA cycles that we've completed so far. So the original Solent document, put into a focus group and having the information and developed and the feedback and develop our own checklist, as well as the quick reference guide. The second cycle being a training package, which is provided by the virtual Microsoft Teams channel, and then feedback led to different approaches, and a specific Teams channel created to allow that open communication between the health visitors and the therapies team. And the third one is that training packages rollout and the ongoing Padlet information.
Brilliant. So we'll just have a little look at the checklist that we've created now. And we, as Jess had said, you know, that the first Solent document that we looked at was rather large, and the information that we had back was that it was a little bit too big. There was quite a lot of pages. But we've still got our big checklist and we've got our smaller checklist. So this is just an example of our larger checklist, and really we've designed it to be an online document, not something that we're expecting anybody to print off. No, you know, that you're going to have to carry around in a briefcase or anything like that. Just really, you know, somewhere that the health visitors can come back to really sort of, you know, kind of look at their concerns to see whether there are any red flags for a particular child that they might have seen. We've spanned sort of from birth to 3.5 years, because we found that those were the key ages really, and the time when the health visitors were involved with the children that they are referring on to us. And we've kept it very familiar. So throughout the documents and all the pages across all of the age ranges, and we've kept the same headings as we go through. The sections tend to get a little bit longer as you scan through as well, just because sort of when you're looking at skills at 6 months, you know, you're kind of looking more at movement and maybe a little bit of communication and feeding, whereas once the child is 15 months, 27 months, you know, there's a lot more sort of intricate detail to look at, and so we've split it out, and the sections get a little bit longer as you go through. We've made sure that we've included sort of a section on when to be concerned, as when sort of as specialists that we would be kind of flagging certain things up that we're concerned about, and definitely when we could become involved and work with the families. And we also thought it was really important to signpost parents, signpost the health visitors, to be able to signpost the parents in turn then towards things that are out there in the community already, universal provisions, some really, really good and powerful websites that are out there to really support parents now at the moment as well. And we wanted to, you know, just make sure that the expectations were being managed as well, so that the first resort is not going to be referral onto specialist services, because there are lots of things that can be done before that. And I think that a lot of the thinking around education is also kind of going in that way, to universal provisions as well, and not just going straight to the specialists. And we thought that the big checklist would also help newly qualified staff. So health visitor training tends to be quite short. I think they do the course within a year, and they come from lots of different backgrounds. So some of the nurses come from adult backgrounds, some come from children, and it's not always possible to learn all about development of children within a year. So we thought that that would really help to support some of our newly qualified staff who are coming to work in the health board as well. So the shorter checklist then tends to, I think it runs on about sort of six or 7 pages. So it's much shorter, so can be printed out to be taken on visits if the health visitor wants to. And we've shortened it to coincide specifically to the Healthy Child Wales surveillance scheme. So they have specific points of contact with the health visitor at sort of around about 6 months, and obviously right from the very beginning, but 15 months and 27 months as well. Then there is another contact around about 3.5, but sometimes that's done in coordination with practice nurses when they're giving the preschool boosters. So we've sort of filtered out the information specifically for those 3 areas, because that's when they will definitely be having a face-to-face contact. And we've again shortened it to really look at the milestones and advice and signposting to give out to parents then. We're not expecting the health visitors to fill this in or do any extra work or you know, tick the checklists at all and send them into it. It's just really to help guide their thinking and to really sort of get the right information and the right examples that we need then to know that this child needs us if they're going to make a request for help to us as the specialist services. And as was mentioned earlier as well, we've put all of this information together into a Padlet. You know, the world is becoming a lot more technological and advanced, and, you know, sort of especially over the pandemic, we were enabled to work really from anywhere, and, you know, sort of with tablets and smartphones as well as sort of laptops and PCs as well. We thought it would be really, really useful to have everything all in one place for the health visitors to be able to access, rather than have to look in lots of different files or ring different departments to get different paperwork. So we use a Padlet as a platform, and I'll click into it in a second, but it's accessible either through a QR code, and you could just hold your phone to it and it opens it up, or through a link as well then. So if you are on a PC, you can go through to it as well. So I'll just stop sharing this for a second and take you over to the Padlet. Okay, so you can see that it's all on one page really, and we wanted it to be kind of like a one-stop shop really, so that the health visitors have everything all in one place. And also we wanted to make sure that it was it was reliable sources of information as well, and you know, it's really easy to go and just do sort of a Google search these days, and to, you know, to come up with lots of different advice and different opinions on things. So we wanted the links that we're giving out to be reputable and reliable sources as well. So we've included the checklists for the health visitors. So the big list is here and the shorter list, and they're really, really easy to access. So when you click on the document, just takes a second to load up, and then the document is in sort of full form right in front of you, and then you can scan through it and take off the information that you need then. And then again, you just click out of the document and it takes you back to the original page. We've included sections for each therapy service as well, including information on how to get hold of each of the services, the request for help forms as well. And I know with physiotherapy, they've got a Microsoft Forms version, so the health visitors can click on that and fill it in. And then also information that we may give out as individual services, then we've been able to add at the bottom, you know, particular for physiotherapy information about tummy time, sort of lying to sitting, some of those really, really nice early skills that often parents do worry about. And again, with speech and language therapy, the same information, but you know, kind of looking at the Talk With Me project that's been spearheaded by the Welsh Assembly government at the moment. You know, 10 tips to help learning to talk, looking at Talk With Me. We've specifically put some information about weaning as well, because we tend to see lots of requests for help coming for sort of eating difficulties and weaning, and around play as well. So there's lots of nice information sheets on here. So if I just click on one to show you, again, it just opens up in a page on its own, so it can be printed off. And then there's nice information in there about incorporating play within the development of that baby. Sort of, this is the 3 to 6 month one, but just types of toys and you know, really nice practical information to give to the parents. We've also included some information at the end about carers as well, because it's often, you know, our caseloads and our parents are often, you know, carers as well. So there's some signposting information for the health visitors there as well. Okay, give me a second and I'll head back to the presentation for you. There we go. So yeah, and I think just the you know, the last thing for me to just say is that really we wanted to make it that it was the same across the 3 counties. You know, we do, however, covers a really big area, and we wanted to make sure that we're able to give the same information across the 3 counties, and that we, you know, sort of there was equality of service provision and access to each individual therapy service across the whole of Hywel Dda as well. So we did get some feedback when we were doing the sessions with the health visitors, and most of them were really positive. We said they were, you know, really excellent idea. It's really nice to have everything in one place. So the Padlet had really good feedback, really positive. They like the advice of what they can do first. You know, sometimes it's really difficult to have that information all in the same place. So it's really nice to have that kind of one-stop shop. Somebody else said, you know, lovely to review the link between therapies, or to renew the link between therapies and health visitors, and that's what we want to do really going forward as well, just making sure that we are visible and that we are there and that we can answer the questions if our colleagues need it. And you know, many felt, you know, really beneficial to the service, and we're really hoping that we would be able to take it on a little bit further then.
So what next? We're really excited about, you know, where this is going to go. And like Emily said, you know, really pushing that 3 counties. And, you know, we really see some benefits and positive outcomes for this project that we're doing. So we're going to be offering ongoing training sessions to our health visitors across the 3 counties. We'd really like to develop a Padlet for parents, so that's something we're already in discussion about. We're going to continue to collect and analyse our data. We will be inviting other stakeholders to be included in the next stages, such as health visitors and parent focus groups. Therapies to continue to work collaboratively. There has been further opportunities identified for teams to attend the EQUIP project 2022 to 2023, and I believe the cohort 3 start today. I'd like to welcome any questions now.
Brilliant, thank you all so much. That was really interesting. We're close on time to rejoining the main pavilion, but are there any immediate questions either online or in the room before we finish up? Just give a couple of minutes in case there's anything from anybody on Teams. If not, thank you so much for the presentation. That was really interesting, and I'm sure will make a big difference. Here, there we go, brilliant. So at that point, if I ask everybody to either virtually or in person rejoin the main pavilion for the final plenary, and then we'll finish off. Thank you.
Thank you.